So from the proposal and what we spoke with Dr. Anish also, I think the three main components that I could see was one, the brief contact intervention when patients are coming with suicide history and admitting in the emergency department, the team is being able to build a rapport immediately and then also register them into the self-harm registry, which is currently in more physical format, which they are planning to digitize it in the Summers project. And right now, how it is being implemented in Victoria Hospital is with a smaller team that is led by NIMHANS, but in Summers, the idea of expanding it to the larger system itself, training being one of the major components. Um, and the follow-up system where regular phone calls are being made to the patients after they get discharged to be able to reduce some of the recurrence of self-harm. This is the understanding I've gotten. Uh, so what do you think are the critical parts of this intervention?
Yeah, the critical part of this particular intervention would be uh, instead taking in the casualty of the place where immediately when they come because they are in the grief. The caregivers, whoever is their attendants, they are in the grief. It is really difficult to talk to them, convince them that time, and then continue taking the history once they're admitted in the medical emergency. Most of sometimes maybe surgical emergency also if there is sort of thing, cut somewhere. Otherwise, yeah, mostly in medical. So that following up next day and talking to them, interacting, keeping that rapport with them in that critical situation is the main difficulty. That is first part. In the first part, second part, the training. I don't think it will be a difficult issue whether it is a faculty. Or the nursing faculty or the medical faculty. Training won't be an issue. Uh, but follow-up again would be an issue. Telephonic, sometimes they may not like to continue the conversation, even though they say yes, because of various reasons when they come here, because of some pressure here or the feeling of, okay, we have to agree, accept that when we are in the hospital. But once they go back home and you call that compulsion sort in their mind will go off. Though it is not compulsion, we ask you are free to know not to do, but still they have feeling some inside it is maybe they have to oblige for that request, but once they go home, they might not. That obligation may not be there in their mind, so they may refuse or they may get a false information. So those issues are more likely to happen. So that is a challenge how we deal with those things. Maybe we also did that in the last the project, our project here in MMC, which was challenging. And again, we thought of asking them like in their follow visits, asking them when they are coming again. So meeting them in their follow visits. Maybe that will sound good in the hospital. We also thought of going to their houses, but we could not do it. But we also, I'm skeptical about how they would take it. The neighbors, when somebody goes and they'll ask why they came, because neighbors may not know the suicidal self-harm attempt, right? So that they may not know. And if there is some mental health component to it, then issues to it, the mental illness is there, then again, the complication increases. So that is my thing. And coming to digitizing, yes, I would say it is definitely difficult to convince the utility of this to the authorities, administrators, and they may keep telling the difficulties. No, this is not possible. This is not possible. So how do we address those things? We should be ready with those points. No, this is the solution. This is the solution. This is the solution. These are the benefits, and it will not hamper your routine work. That kind of information is required. So they are comfortable acting, willing to, like, okay, you go ahead, do it. Because as such, uh, all records are still not computerized. OPD is computerized, but inpatient record is still not computerized. They said we will do it. I don't know. It wasn't 2 years back, but I think it is still not done. So maybe there will be difficulty in convincing the administrators that this would work, and also to say that this will not come in the way of their regular work as such, because the record section faculty is also in shortage compared to the work case loads. So they may find some issues. So we have convincing them is a challenge. Convincing the medical record section people is also a challenge. So maybe we need to any change would always there will be some resistance. So even though we do it in the project part initially, so they must be okay with that. But giving space, there will be difficulty, even if our project staff is staying there. Because we did face those issues last time also, but they somehow agree. But there some days they say, okay, this will be too crowded. You don't come on these days. So there was some issues like that. So we may have to be like uh, flexible with some relation to some of these things. Yes, maybe we must be ready to skip 1 or 2 days in a week, days where it is going to be very hectic now, so where nobody can sit there. And also a transition phase, like where we think, because we are thinking this as more of a implementation research, even when project is off, these things should continue. If we are thinking that should be the ultimate aim, and that there will be a lot of difficulties and risks. Okay, if you want to do it, okay, 1 year, 2 year, okay, you do it. But afterwards, don't ask us to do the continue this. So maybe in the transition phase, we need to handle them. So we need to have that transition phase, and slowly a smooth transition has to happen so that they will take over without feeling the burden. This is true for any implementation research where when we have to make it regularize those activities. Uh, yeah, so that is the difficulty. So these are the challenges I feel would be there we do this intervention.
Understood. This thing about uh, staff not getting space, do you mean like in the emergency department?
Emergency, the cases which they take, they won't take it in emergency. Like you have seen the MMC setup. So it will be in the casualty. And
Hmm.
yes, their space is not an issue, but they have to stand. There may not be space for them to sit. The whoever research assistant is there. So that is okay, somehow adjustable. And we have to plan the night and day shifts because more cases come in the evening and later part of the evening. So they need to have some space to take rest also. So that is an issue there, actually. That is an issue. In the previous project also, we faced that issue. So we need to have some space where they can sit comfortably, and when the case come, they can go and interact. So that sort of thing. And daytime, obviously, there will be, there is an issue because you have seen that there is 2 3 beds here, and then there's the interns and the casualty medical officers sit one place. The other place, there is nothing. And inside, it's a stomach wash area. So we have to have some arrangement for that also. And then I was talking more about the record section,
Hmm.
where the research staff, the project staff have to see. So there's a lot of congestion of lack of space in the record section, medical record section.
Hmm.
So both the places it is there, but more with the records. But again, night time it will be a problem even in the cloud.
Hmm. So I think you've laid out the challenges. I could note them down. What do you think, like currently, how the care is being delivered? what kind of practices are happening with respect to self-harm or suicide attempt patients, and how will that become different in this intervention? What kind of change you expect?
Right now, whenever the patient comes in 9 to 4 or any self-harm any time, we go directly to the casualty. The casualty medical officer will take the brief history and do first aid kind of thing. The signature medical legal aspect, he'll take care and then send to the medical or surgical. So then they treat at just before the discharge or 1 or 2 days before the discharge, they will be referred to psychiatry. So they will take care of the other aspect. Sometimes they also do inform in between, like second day, third day, as soon as he or she is relatively better, a psychiatrist then may come, may not come psychiatrist because the busy schedule. But before discharge, definitely psychologist will come or they will be sent to the psychiatry department when he is able to move. And then there is no follow. So if they will be asked to come for the follow, but it's their wish. So nobody knows whether they really come or they don't come. There is no tracking of the follow. And even the records, as it is not electronic, so it's all be there in the case sheets, even in the admitted case details. And after that, definitely there is no follow-up, there is no tracking of the cases. There is no system of that. So when they come next time, I don't think they will be registered online again. Because once OP slip is there, it is valid for 1 year. So they will with the same thing discharge card, they'll go to OPD again. That will be noted in the OPD. So how many of them actually came back? How many times they came back? What happened to them? Nothing will be. And how is the progression? Progressing? So nothing. We don't know. And whether they come or not, also we don't. So I think this will be an opportunity to track that, create a system of tracking them. Instead of, this is my feeling, instead of making a separate software uh, which can have this tracking mechanism, if it comes within the purview of the project, better to modify the existing software where they can track. So that will be useful for even other non-communicable diseases like diabetes, hypertension, and that would be a huge difference which we can make, including asthma diseases where we can track it. But I'm not sure how it comes within the purview of or even if we make separate thing, right now that thing can be done by the project staff. But once they have this knowledge of how this software is done, we can inform to the this particular whatever software is there in the hospital throughout Karnataka, and same thing can be integrated that part, the cohort part or follow part, so that becomes a full-fledged, better care for everyone.
So one main difference in the current system would be this tracking and follow up that you're saying.
Yeah, so
In
which in
terms
turn may reduce
of,
the repeat attempts and then we can prevent the deaths.
hmm. While they are still in the hospital, do you see still a difference that might happen because of the intervention? In Victoria, what we heard is this referral is also not happening from the emergency or medicine department to psychiatry department. But here, at least, it seems to that might seem
It
to
is
be.
better. It's not 100%. I'm
Hmm.
also not telling that it's 100%, but it is better because of the previous project. So that we trained the various medical emergency anesthetists and surgical emergency staff. But this will help in preventing the repeat attempts. So we are reducing the mortality. So that slightly changed the practice of these physicians. So There is some referral, definitely. Not 100%. We don't know after the project how much referral now, but definitely there is some referral.
And what do you see a difference would happen because of the intervention while they are in the hospital? I got what you said after they leave and the tracking becomes easy and follow-up is provided.
But probably the referral may be early to the psychiatry, and also it will closer to 100%, or there will be improvement in referral. One is early referral, and then second is the complete, at least some referral will be there. Compulsory referral can be, we can expect that. So again, which in turn decreases the mortality repeated. But I'm not sure, no, uh, if we are uh, doing this, are we having giving extra? Maybe during the project time, research assistant, if he gives the counseling or something, then maybe benefit. But this may not by default increase the referral because they will take the details. So, but are we assuring or ensuring the referral to psychiatry? Because again, uh, manpower issue is always there in the psychiatry department. So even if we refer, how are we strengthening that part? I'm not sure. Maybe referral will increase, but the quality, the quantum of referral, how it will improve, I'm not sure.
This
But
person that
definitely
you
there will
see,
be some benefit.
hmm, this person that you're saying who might take details of the patient, do you think they are also delivering some sort of intervention or support when they're taking these details apart from the details itself?
Pardon, I could not hear. Who is the research assistant?
Research assistant who's making this first contact with the patient. Are they
Mhm.
also delivering some intervention apart from adding the details into the registry?
So that I'm not sure. I'm not sure. That part I'm not sure. What is planned now? Uh, if it is delivering some intervention, then that will make a huge difference. That will make a huge difference.
What kind of intervention might make a difference at that point, you think?
Maybe just talking to them and then why, what happened, why it has happened, probably just talking only, in addition to just taking the data, itself make a difference. And then slowly, they don't know so many things. Why it happened, what is going to be the prognosis. They have one important question. Most of them would have why it happened. So if the just a conversation itself will give some solution to the caregivers, uh, and the consolation also will be delivered. So, because of the experience, the knowledge of the research system, if you tell, okay, these things happen, how they can prevent it. During the conversation, a lot of things can happen. The prevention aspect, the follow-up aspect, uh, convincing that, explaining them why this can happen. So that itself will be a great interest. And also helping them where to go, what to do next, sort of thing. But yeah, that will be a burden to them. So you may have to have depending on the number of caseload, you may have to have multiple people. So one person, then it is really difficult because if he is involved from talking to one person, the care attendants, then he will not be able to take the next place. So it used to be in, say, at least pairs, so that no, if one person is here, then that other person can contact people. The next case. So those things come. So they can take turns and one after another. Okay. Otherwise, it would be difficult.
Then do you see the training aspect as one of the interventions? And if so, like who would be part of this training? What would the training look like and what can that lead to?
Training would be for, I think it should be for all cadres, right from the group B who shifts the patient, the IRs who talk to the patients, uh, and IR, all group D plus the nursing staff and then the doctors, both surgical and medical specialists. Maybe even the way that they talk to the approach with the patient need to be streamlined, including like let's say ENT when they do tracheostomy, if there is some hanging and some complication. Maybe plastic surgery, plastic surgery faculty because the burns if they come there. So all specialties of all level, um, uh, except except maybe OBG, but still, no, there are still many cases of antenatal care with self-harm issues. Suicidal do come; it is not zero. And also the pediatrician. The pediatrics cases, the self-harm cases are increasing. So yes, pediatricians also need to be. So they also to be involved in that across the specialties, across the care would benefit.
Hmm. One you said the training would involve like the approach to such patients and the care. What else
Referral,
would
approach and referral.
referral? Hmm.
Referral to
Hmm.
second. And also
Do you
when they
see
keep talking about the importance of all if the respective specialty also talks to only psychiatrists talk, then they might not give uh, the importance to it. But when the other specialty doctors, whoever is taking other physical physician, the physical caregivers also talk about this, maybe it goes deeper into their mind and they do respond.
So you see them as more like the support system for psychiatry department. Do you also see them as they themselves delivering some of the psychosocial support, or
I
that's
think
too
that is
much to
what
ask?
I meant approach. When the approach with which they deal them, it will act as an intervention to the patient.
Hmm. Has this already been tried, like in MMC or some other place where other cadres are involved?
Other cadres no, were not involved, as far as I remember. But doctors, like some of the doctors were trained importance of referral, mainly focusing on the referral. And they are also trained about the diagnosis, especially medical and anesthesia, critical care faculty, and psychiatric illness identification to the GMATA.
Can you tell us about that aspect of training, your experience around it, how acceptable it is for the staff, and
They
especially in
mainly
terms
why
of
us?
practice?
Yeah, why do you want them to us to do the psychiatric part? So why we have so that will be there. So very few turned up to from each institute. We did cover JSS, Mission Hospital, and Mysore. Some staff came, some maximum, some around 10 staff faculty came. That was the only one training which we did. And then I will not see any change in the practice, significant change in the practice in terms of diagnosis, but referral, there was some, it was a one day training program. actually not even one day. I think half day it ended. I think many of them went to the afternoon. So it was more like an half day training, talking about importance and the easy identification tools that EMI and then what they can do. But uh, except for the referral, nothing much improved.
Hmm. What what do you think then can be done differently, or like what in that help? Probably this referral bit at least, and what do you think? Maybe we'll have to think in this trainings.
I think we have to do a circular that is administrative and maybe some brief voice message on why they have to be part of the training because nobody reads. So it's just video or audio message. What's the importance, why they have to attend, and then it should be completely made as case-based discussion. I think we did have some case also that day. Time. So case vignette, and then their role specifically is dealt done as a workshop. And full day or half day, whatever. So we need to be very crisp and with the case scenario based workshop. What they can do about it. Maybe some videos of the communications or demonstration of those communications. Hmm. Even if it is half day, it has to be this. And take appropriate example for each of the specialty. So the training material preparation has to be very well thought. And then definitely training will be useful. And also show examples from uh, other places in India, if it is there and elsewhere in the world, how such intervention help to improve the care. So if they get proof of change in the outcome uh, and theories why it can change, probably they will give initial part of the training itself. Then probably they'll give more attention and then maybe bring change in the behavior practice.
Hmm. So, what do you think would be like reasonable outcomes to expect in this intervention?
Uh, if reasonable outcome would be there will be some system of recording, keeping the register, and then tracking, follow, referral. Maybe some difference in approach, some difference at least. Because behavioral changes are difficult to happen, maybe need some more reinforcement. So maybe, project if it has some kind of uh, reinforcement mechanism for them and show the quantum of behavior change which has happened in between after some time and then reinforce with something. Maybe we can improve that behavioral change. But
Hmm.
these other things, like those are not really the behavioral part, I would see expect them to be a greater change.
Hmm. And in patient outcomes, do you see any change because of these changes of recording
Yeah,
and
I would
tracking?
definitely see change in the outcome. I expect decreased repeat self-harm and improved follow-up. If everybody talks about the importance of follow-up, definitely there should be a change in the improvement in the follow-up. So once we have better follow-up, there will be lesser repeat of self-harm and then yes, prevention. Not
Hmm. After the intervention, like after the period of the study also, do you see these outcomes to continue or any change in those?
Provided we empower some mechanism for continuation of registry and some sort of when we recommend to the government, uh, that is what I said, a hand holding. Some
Hmm.
counselor always being there, some mechanism, at least like during the transition, and then by the time transition happens, we recommend government and ask some of such with some evidence, usefulness of such people being there. So once project staff goes, some permanent recruitment for that thing should happen. And then yes, I would say yes. At least that. Now, that is the only thing which needs additional empower, right? Rest all can happen with an existing staff. So this one staff or two staff per institute income in a tertiary care and one staff in a secondary secondary care would definitely will make a difference even after the project is taken.
Hmm. I do have question about the transition and how that could look like. But before that, Vaibhav, do you want to come in? If there are any
Uh,
questions.
yes, thanks, Swati. It's very clear to me, Dr. Suman, based on what you shared, what you, in your opinion, are the components of the intervention and what outcomes you expect. Can you also elaborate? I mean, to some extent you have, but if you can elaborate more on how do you see these components being connected to the outcomes that you expect? Through what pathways? I mean, in your opinion, how they are connected?
Yeah. See, when the patient comes, is the attenders and the patient, they come either in the distress. So some kind of consoling what is happening because the medical officer is interested in medical legal aspect, noting it down, and the others are busy in the emergency, busy in the physical care. So just kind of consoling that itself, initial phase will help them, and then sometimes or many a times what happens, they don't know what to do. At least the first 24 hours, what to do next, where to go. So all those, there's some kind of full-time support, some 24-hour support. Somebody is there with them to direct them what to do. So that would help them to ease the stress in the attender. And uh, of course, when there is a referral to psychiatry, the follow-up helps it to identify any medical illness is there, mental illness is there, whether it's transient or long term. And once follow-up is done, so that will take care of slowly easing out the issue, sorting out the issue, and so which will in turn decrease the repeat self-harm and then death. So I think this
Thank,
is the mechanism.
yeah, thanks.
And
That's very useful.
recording the electronic record keeping helps us to get the data and analyze and get into the common causes. So how, and then yes, policy decisions for those things. So we have some data to understand self-harm better way, which helps in policy changes.
Thank you. That is very clear. Back to you, Swati.
Uh, the aspect about, I mean, maybe I'll come to the transition later because now you've already laid out the pathways. Maybe you can share from your previous experience of self-harm registry, what kind of things that you've seen from that work, like some assumption that you had made before, but that was challenged when you saw how it played out, or be it like acceptance of the self-harm registry itself, or whether it helped the patients or not. Any insights you've got from that that can be useful for this intervention?
See, the registry helping the patients directly, we could not appreciate that much because it was not done for the period which we intended to do. So this because of COVID, it was cut short abruptly. So it was done only for smaller time interval, a very shorter time interval. So we could not do that. But yes, from the research assistants feedback, we got that, as I already told, so they were really helpful for the patients. So patients were in distress, they did not attend us, they did not know what to do. So that really helped. Uh, also, so whatever I spoke in the beginning, from the beginning, it's all based on the experiences from the previous project, most of. So even the place, the no place for them to say. So all those issues are the challenges are from the previous experience. And the record section interaction, I said, the space issues. Initially, they were reluctant, but later they became very close friends. The research assistant and the work employees there. But some of the days they said, okay, please don't come these days in the week because some other work will be happening. Because they have to sit in the corridor only. Extra table and chair was given to sit in the corridor. But that corridor used to be full on some of the days. They said, please don't come on these days. So like that, so all the challenges. Uh, Transition never happened because of COVID, it was cut abruptly and then yes, we had to stop. So there was no transition thing. Yeah. I think I already told most of them.
Hmm. Yeah. Yeah. I think even the institutionalizing this or transition part of this, you have kind of laid out that there are some critical people you may not be able to eliminate and you'll have to hire them even from the government's end. Is there any other things that you see are required for it to get institutionalized, this whole intervention?
It should be made like this is a part of national mental health program. Then when the word national health program implementation comes, everybody will oblige to it. Because they keep, even though it is was a project and then you are thinking of making it as a routine practice, suddenly they'll think it's a project only they're trying to implement. So unless they say, okay, now the order, so we have seen this, we have done this, and now we have seen the improvement in this area. So now it is a part of the program now, as per the National Mental Health Program or District Mental Health Program. So it has to be implemented. Such order should come from the health secretary or the mission director somewhere. So then definitely it will be implemented. These things are must to be done. So that kind of thing. And the employment of one such counselor also has to be is compulsory, mandatory. And when that letter comes, only then it will be then that will happen. And that should be part of their auditing. Psychiatry referral. For example, we do have Kalpa as a quality assurance uh, tool, so measurement tool. So if we include those criteria also in the Kalpa, then only it will be. Otherwise, it will never be implemented. So why we have to do it? They have done some project, so why should we do that? So that will be the mindset in every institute, not here like measurement in every institute. So once it becomes a part of the program, becomes part of auditing or evaluation of the working of the institute, then we
This district mental health program or national mental health program, currently, is there anything, any components of that being implemented in the hospital? Is there a
they
uh,
have a
natural
set of
connect, you see?
only one connectivity in the tertiary care. The two connectivities. One is the availability of drugs, the psychiatric drugs, and the psychiatry faculty going as trainers. So only two components are connected to the medical college, tertiary care. The rest of the things are all from the district psychiatrist who will deliver, and the PHC, and primary and secondary. I think tertiary care, these are the only two components.
Mm.
So, but if at the end of project, if we bring the registry of the program, definitely then it will be implemented.
Mm.
Because
The
according
training
to me,
also.
that, yeah, training. According to me, training of all the healthcare providers, all the other cadres. So if that is compulsory, like how the training is happening on all other national for all the healthcare. So likewise, if it also becomes part of it. And again, primary and secondary care is much more important, but I'm not sure still whether we have included that in this intervention. Because that is the thing which will change, and then referral from here, that's the secondary care, registering those who are at risk at the primary care, secondary care, like how we do for diabetes, hypertension, and cancer, the risk and then screening. Likewise, if it comes from the ASHA level in a suicidal ideation, risk assessment for those who are at risk, and then the next level, registering such people, referring such people to the next care. So that is my kind of an ultimate dream of all based on the previous project. But unfortunately, we could not do that at primary, secondary care level intervention. Still, we are stuck
Mm.
in the tertiary care.
Mm. One other thing I wanted to ask is, so in yesterday, when we had a conversation with Dr. Rahul, he was saying how felt needs of the patients who come could be different from what we want to deliver through the intervention. So, in your experience, how has that, how have you seen what the felt needs are usually when they come, and how intervention can at least bridge some of that?
Yeah. So again, it connects with what I told previously. When they come, they're least bothered about follow and other things. What they want, what to do now, where to get this item, where to get this, where to go. Those sort of things they're immediately bothered about. So if we give some informations related to that, ready thing help for them, ready reckoner for them. Hey, here you should go, this is what this is help, you get these things. So that kind of help, that will help them to bridge with this project.
And many of them might also come with some social issues which would have driven them to self harm, no?
Yeah,
So I understand there will be some limitations to the intervention also, but do you see it addressing some of those underlying causes, or how can it
definitely.
be thought of?
Yes, definitely. Like what I said was in just initially few hours or one day, but after that, slowly, this project can do the intervention related to that. So when they keep talking, then comes why, though immediately that will be there, but immediate uh, support requirement is different. But after one day, definitely that comes down to why, what happened. So these are the issues, everything, identify the issues. So then maybe when the council discuss those issues may be supported, or at least the attenders may get some clarity. The patient himself may get some clarity of that. So later, second part, after one day or 2 days, we slowly, this aspect can be focused and will help them.
So I think this was very helpful. We've gotten all the insights of what this intervention can look like, and including the challenges and how it could work and the outcomes. Vaibhav, did you have any other questions?
Only one last question. If you can also elaborate on any important assumptions you feel that are sort of already considered in all this process as part of the samasta.
I think the administrative difficulties are already assumed and considered in this thing. That's what I feel.
Okay. And some things that are assumed but may not turn out to be so, in your opinion. Um, if I can give an example, it may not be relevant perhaps directly. Let's say we have assumed that all the clinicians will be interested to uh, take part in training and implement it. Do you think such assumptions are there, which will be important to acknowledge and be aware of?
I don't think we assume that. We assume that the other way we assumed it, but it may turn out to be the other way also. But we
Okay,
definitely
right.
assume that they may not
Hmm.
respond,
Hmm.
they may not be interested. Similarly, with respect to the see, these things, many new things will always be resistant. Especially people, clinicians, they can also be of some importance in psychological.
Hmm.
And again, that might be a wrong assumption. Might be a wrong assumption.
Yeah, thanks. Yeah.
Right. Can I get a recording of the terms of link or where I can? At least audio
I'll
form.
add it to the drive and share it with you.
Thank you.
Thank
Great.
you.
Thanks a lot,
Yes.
Dr. Samant.
Oh,
Yeah.
Thank you both.
yeah. And I'm really happy to talk to you. Why?
Yeah.
But I think I don't know if I've already told you. Like I was Dr. Suman's student, and very early, I think he has
Oh,
influenced
I didn't know
me to
that.
take the public health route. Yeah. So
That's really nice.
I was very happy to see you, Swati, the stature which you have grown. And yeah. And the first thing, you took the public health, and then second thing, the way you have grown. Yeah. Happy to
thank
see that.
you.
Thank you. Have a
Okay.
good day.
I'll just stop recording.